Testando o som. Ela é muito mais bonita que eu, né, professor?
Isso qualquer um é muito mais bonito que eu. Até eu sou mais bonito que você.
Aí fiquei em desvantagem, pô.
É, até sua cachorra é mais bonita que você.
Ela é maravilhosa.
Você viu a cachorra dele? Não. Bulldog. Bulldog francês ou inglês?
O dog inglês, ó. Olha lá.
É um bicho bonito. Muito mais bonita que você.
Você sabe que ela fez uma palatoplastia um mês atrás.
É você que operou?
Eu não, veterinário, né?
Ah.
O palato mole dela entrava na glote.
Ixi.
Maravilhoso.
E a pinéia?
A pinéia, nossa, ela tava dormindo em pé. Eu não achava
Não vi,
uma posição para pôr a cabeça assim, coitada.
Você está brincando, mas eu tenho um amigo que é veterinário e um dia a cachorra dele teve que fazer uma parada de urgência e é que ele não me achou, mas ele queria que eu que operasse, viu? E o cara é veterinário. Verdade, não é brincadeira.
Tem
Acho que a
segredo,
nossa
vai.
formação como cirurgião é mais efetiva do que a dos veterinários. Né?
Ah, com certeza, né?
Bom,
Então tá
Leandro,
bom.
o André já está aqui, estão esperando a Sara entrar. Você
Ah, o
vai ser
Bambi
o
tá aí?
último
Não
a
tô
falar.
vendo. É.
Está aqui.
Opa, minha senilidade hoje deixou eu ser o último, então.
Você vai ser o
Senilidade.
último, tá?
Beleza.
Certo.
Fala, Claudião.
Ele convidou. Opa! Quem que é? O Flávio que está aí?
É o Bob.
Bob.
Mas você não está em cara, só está em voz. Você é um espectro sonoro aí. Onde você está?
And now? Eu estou em casa.
Oh, yeah.
Mas não está aparecendo você, só sua voz.
Ah, que bom. Mas a minha cara você sabe, conhece muito bem.
De longa data. De longa data.
Salve, professor André, bom dia.
Obrigado por ter aceito aí o convite, hein?
Imagina, um prazer.
O Gustavo estava meio preocupado, que ele falou que você é muito bravo, tudo, mas...
Boa tarde, doutor Medina, tudo bem?
Ô, grande. Eu sou bravo. Como é que é isso aí, pô?
Brincadeira, brincadeira. É brincadeira. Cadê o coisa em inglês
Ah,
aqui?
que bom.
Você mandou para mim, né?
O quê? Aula, sim.
Revisão, já fiz. Expressão, Bom. Tudo bem, eu acompanho o português. Na verdade, eu não vou falar quase nada. Né? Estamos esperando só a Sara. Agora eu estou vendo você. Agora sim.
Opa!
Now, yes.
Alegria ver o senhor, professor.
Vocês estão...
Aqui, estou meio escondido.
Opa, tudo bom? Vocês estão aonde?
No primeiro andar da faculdade. No térreo, né?
Que bom. No térreo, que bom. Saudades. Saudades desse lugar.
Aqui estamos nós.
Que bom. Curtam bastante.
Obrigado. Não estou achando o seu em inglês aqui, mas vou acompanhar. Como é que estão as coisas aí em Floripa?
Graças a Deus, tudo bem. Já tomei as 2 doses da vacina. Novembro eu tive um quadro muito leve, então eu imagino que eu esteja imunizado. A Cristina também já tomou a primeira dose. E Floripa teve muito ruim agora em março, mas agora já está começando a melhorar e sair do crítico, sair do vermelho.
Aliás, meus pêsames a vocês catarinenses pela tragédia de ontem, né? Que absurdo, né?
Não, uma coisa completamente absurda, né? Como é que pode um negócio desse acontecer aqui, né? Que coisa, numa cidade zica de nada.
Mas sabe o que aqueles caras estão pesquisando? Pelo menos eu li no Estadão de hoje, que linha que eles estão seguindo de investigação. Sabe esses grupos malucos de internet aí que os caras fazem uns desafios? Teve uma época aí um monte de suicídios em jovens, não sei se você lembra dessa história, que é a mesma coisa.
Ah, me lembro, tal de
então, parece
baleia
que...
azul lá, baleia alguma coisa.
Isso mesmo. Então, agora, parece que é um grupo de jovens que também fez um desafio de quem matava mais criança, um negócio desse.
Meu Deus, que triste, hein?
Bom, mas então, vocês que são catarinenses, meus pesos. Você já é catarinense agora, né?
Eu já prestei o exame aqui, acho que passei já.
Que bom.
Ela logando.
Hã?
Ela está logando. Tem log não.
A hora que a Sara entrar, vamos começar a falar inglês, ok?
Exato.
Opa! Aí, ó.
Café.
Beleza.
Para dar mais cooptação para mim.
Tem até adoçante, não tem?
Tem adoçante e açúcar mascavo, vocês gostam?
Açúcar
Cláudio,
mascavo,
para
legal.
de puxar saco do professor Cláudio, que ele não merece, viu?
Olha, eu depois vou fazer alguns comentários com a professora Maria José sobre essa... açúcar? Por essa rebeldia intolerável.
A doutora Sara veio com uma nota no WhatsApp, a gente até mandou os e-mails, tudo.
Eu comuniquei com ela agora, ela está fazendo o login. Ela está entrando em
Se
breve.
vocês quiserem alguma coisa, vocês mandam pelo WhatsApp, que a gente está sempre de olho. E às vezes vocês falam uma coisa. A parte de suporte daqui, se der qualquer pepino, os meninos da informática estão assistindo junto com vocês.
Ah, é?
Então eles percebem quando está ruim, tá bom? Se alguma
Tá bom.
coisa travar, alguma coisa assim. Tá bom?
Obrigado.
Obrigado, querida. Você, como sempre,
Imagina, precisa
ótimo.
ser.
Né?
Eu só não vou clicar aqui, porque se você fecha, não dá deitar, tá?
Tá bom. É maluco, né? O aplicativo
message.
Blue Jeans.
Mensagem normal.
O quê?
Eles não usam WhatsApp nos Estados Unidos. É só
Usam, vários
mensagem.
deles usam. Vários deles usam.
Sério?
Nós temos um grupo de WhatsApp da diretoria da IFES, por exemplo.
Mas tanto é que os Apple Watches, as coisas, nem tem e-mail, a plataforma do WhatsApp, você consegue usar bem melhor a mensagem do que propriamente o WhatsApp para ver as coisas.
Bom, só estamos esperando ela aí, né?
Eu não está alugando muito bem. Mas vai aparecer a qualquer momento. Vou deixar o sentar no modo avião até que ela entre.
Deixa eu esfriar um pouquinho, senão eu vou queimar a boca.
Café queima mesmo.
Opa! Acaba com 2/3 da potência sexual do homem, né? Queima a língua e o dedo. Se cair no colo, então é 100%. Talvez até um pouco mais. Depende da idade, né? Vocês são muito novos. O Vinícius de Moraes, uma das suas inúmeras poesias, ele dizia o seguinte: enquanto tiver língua e dedo, de mulher alguma terei medo. Ih, acho que a sua esposa está vendo isso, né?
Acho que tá.
Sorry.
Inclusive, um monte de gente que já está ligado.
Já está ligado.
Oh,
Oh my God.
Grandes ensinamentos, né?
É, bom, obrigado. Hein? O pior é que eu estou falando
Sempre
baixinho.
ensinando, né, professor?
Eu estou falando baixinho aqui para ver se não pega no microfone, mas não estou sendo feliz, não, né?
Ele falou que a sensibilidade...
Olha, eu tô um andar para cima de vocês aí e ouvi.
É mesmo?
É,
Tá no link?
tô no link, tô aqui no link.
Tá bom. E a Sara?
Login e... Login e
Apareceu que ela estava ligada aqui.
Aqui pra gente ainda não apareceu, não.
É que vocês estão muito longe.
É, o logo dela tá aqui, sim.
Professor Pei, do you hear us?
Yes, I can hear you.
Oh, good. There is some echo.
Maybe it's because I love the blue jeans. So
Maybe we start now.
No. We need her to be. Oh, there we go. Oh, welcome. Good.
Hi, Professor.
Do you hear us?
Yes.
Okay. So, welcome everyone. This afternoon, we have the pleasure to receive some very important professors here to be the board for the final exam of the PhD thesis of the candidate, Dr. Gustavo Nunes Bento. This thesis is about molecular factors in cutaneous squamous cell carcinomas in the head and neck. We have a very distinguished group of professors here, and I must say that it's it's very honorable for us to have here, for the first time in our department, a professor from Harvard Medical School, Professor Sarah Pei. We have links with this very important institution. In fact, Harvard Medical School is a sister university and a sister faculty of this very faculty, the University of São Paulo School of Medicine. In addition to that, we have links. Several professors of this institution have links with professors in our area, head and neck surgery, with this institution. And one of them, for instance, came here several times, and 2 times actually in our thyroid surgery course, Professor Gregory Randolph. And so we are very, very honored to have, for the first time in our department, a professor from Harvard being part of this very distinguished board of examiners. Professor Sarah Pei is an associate professor at Harvard Medical School and at Mass General Hospital. She graduated summa cum laude at the Dartmouth College with specialization in biochemistry and molecular biology. And she, when I had the opportunity to meet her for the first time, she was faculty at the Johns Hopkins School of Medicine in Baltimore, when I had the privilege of being a visiting professor there. This was back in 2013. And that's exactly where she concluded her residency. And then in 2007, she became a faculty there. And I believe that in about 2014 or 15, she moved to Harvard Medical School. She is one of the few professionals in the head and neck area in the whole United States to have a SPOR grant offered by the National Cancer Institute, and this is a very distinguished honor. And Professor Pei, it's a real privilege to have you here as a member of this board. The other 2 members are from here, from Brazil. Dr. André Bandeira Oliveira Santos. He graduated in medicine in the Santa Casa, São Paulo Santa Casa School of Medicine, and we had the privilege to have him here as a resident in general surgery, a resident in head and neck surgery, and presently He also defended his PhD thesis here, and he has a special interest in skin cancer. Presently, he is an attending surgeon at our Cancer Institute here. So thank you so much, Andrea, for being here. He's here physically with us.
Yes.
And he's also a professor at another university, 9 of July. Last but not least, Professor Leandro Longo de Matos. He is a head and neck surgeon. He graduated in the University of ABC School of Medicine. And then that's where he did a general surgery residency, head and neck surgery, and also where he presented his PhD thesis. Some years ago, he moved to our institution where he presented his full professorship thesis, and now he's an associate professor of head and neck surgery here in our service at the Cancer Institute as well. Also, he is presently the scientific director of the Brazilian Society of Head and Neck Surgery. And so, thank you so much for accepting the invitation for being here. We have also in our screen another member of this board, because let me just explain for you how it works. Incidentally, I am Claudio Cerneia. I am a professor of surgery of this institution, and I am his mentor for the PhD. And I will work here as, well, not the Queen of England, but the King of England, because I won't obviously criticize anything on the thesis, because I am his accomplice on that. But I will control the time, and I'll call the speakers. And after the first, the candidate will present his thesis, then the three speakers in order will make the comments and ask questions. And after that, we will secretly deliberate about the approval or not of the candidate. So there are three professors who are going to decide. And we are lucky enough to have also another professor who is like on the bench. In the case we need him, Professor Luis Medina dos Santos, who also, he's a former member of the faculty of this very hospital, of this very medical school, where he graduated as well, and he did his residency here, and PhD and full professorship thesis as well in skin cancer, in lip cancer actually. And now he moved, I think 10 or 12 years ago, to the very nice state of Santa Catarina, where he divides his time surfing at the beach and operating head and neck cancer patients. Dr. Medina, Professor Medina, thank you so much for being with us as well. So,
thank you so much for the kind presentation.
Okay, so we invite now the candidate, Dr. Gustavo Nunes Bento, to present his thesis, and after that I'll call the examiners to ask their questions, his or her questions. So, Gustavo, you have between 30 and 50 minutes to present.
Good afternoon to all. My greetings to the members of this board. It's a great honor to be here and to have such a selected one. Thank you for accepting my invitation and dedicating your time. I was graduated in med school at the Federal University of Santa Catarina. I did my general surgery residency at that same institution. Later, I came to this school to do my head and neck residency, and now I belong to a service in the south part of Brazil that performs more than 1,000 surgeries a year, almost 30% of that are skin cancers. That's why it's such an object of my interest. I'm also a medical school teacher at the university in the city I live. I will present the teaching class named PD1, PDL1, PDL2, and CD8 in high-risk head and neck cutaneous squamous cell carcinoma. Introduction and lead review. The incidence of down melanoma in skin tumors corresponds to 30% of all new cases of cancer in Brazil every year, reaching almost 200,000 cases per year. BCCs have always been more common, but the incidence of squamous cell carcinoma has been rising more than BCCs, causing their incidences to be approaching. SCC's incidence grows in patients over 60 years old and tends to fall in those below 45, probably due to the use of sunblocks. According to the UN, we might have 3 million cases a year, but some papers talk about 4 or 5. About 10,000 people die each year from cutaneous squamous cell carcinoma only in the USA, and more than 20,000 worldwide. It affects both genders equally. It's more common in light-eyed Caucasians. Its most important risk factor is UV radiation exposure. However, immunosuppression like HIV and tacrolimus, marginal ulcers, and genetic disease like Xeroderma pigmentosus are also important. Environmental factors such as the defect on the ozone layer, especially in the south hemisphere, and artificial tanning are also important role. Suppression of the TP53 and the appearance of KRAS and HRAS are the most common genetic alterations. It usually presents itself as a hard and painful nodule that starts to ulcerate and infiltrate adjacent tissues. Cervical or parotid nodules can be palpable, they can be metastatic or simply inflammatory. CT scans and MRI can be useful to define real size, patterns of infiltration, and the presence of node metastases. Incisional, excisional, or fine needle biopsies are usually required. When we talk about T-staging, most important factors are size, thickness, and infiltration of adjacent tissues. End staging follows the same used as mucosal head and neck squamous cell carcinoma, which tells me that this can be a very aggressive tumor. Positive lymph nodes may rise the incidence of recurrence in up to 30%. Other prognostic factors are degree of differentiation, perineural invasion, and location, especially in the head and neck territory, and how we can see here in a facial mask. Some subtypes are also more important, like spindle cell and acantholytic tumors. Treatment is based in 4 modalities. Surgery, margins range here from 4 millimeters up to 1 centimeter, depending on size, infiltration, and whether if it's a recurrence or not. Parotid and neck dissections may be necessary if positive lymph nodes are detected. Primary radiotherapy can be used for those patients with no performance status for surgery or who do not want the functional and aesthetic outcomes provided by the surgery. Post-surgery radiotherapy are used mainly for positive margins or positive lymph nodes. Cytotoxic drugs are used for palliative care or distant metastasis. Its use for post-surgery treatment is controversial. FDA and Anvisa have authorized the use of anti-PD-1 as a second line of treatment for squamous cell carcinoma. Well, there has been an attempt to understand the interaction between immune system and tumor cells and why the immune system fails in avoiding tumor growth and spread. In this schematic picture, we can see the classical knowledge about this interaction. As you can see, we have antigen presentation, the production of antibodies, and cytotoxic activity releasing interleukins. Cell death is promoted through apoptosis, necrosis, and autophagy. However, in the end of the 20th century, Hangzhou and his colleagues first described PD-1. In 2000 and 2001, the groups from Mayo Clinic and Cambridge genetic groups first described PD-1, PD-L1, and PD-L2 ligands. But what is PD-1? PD-1 stands for programmed death. It's a negative signal. It binds to PD-L1 and PD-L2. It presents on cell membranes, but also in the CD4 and CD8 cytoplasm. Has a predominant activity in the peripheral environment. They are expressed in the later stages of immune activity, mainly on exhausted CD8s. There is no relationship to death. There is a strong relationship with cytotoxic activity. It is a transmembrane protein with an extracellular variable immunoglobulin-like binding domain. Has a cytoplasmic domain containing two immunoreceptors, tyrosine-based inhibitory motifs, which promotes the dephosphorylation of important proteins and making lymphocyte activity to end. PD-L1 and PD-L2 are transmembrane glycoproteins with IgV and IgC domains in the extracellular portion of the cell, while they do not appear to have an intracellular domain, so they do not have a defined role in the cell. Both PD-L1 and PD-L2 are present in T cells, B cells, dendritic cells, macrophages, neutrophils, normal tissue cells like kidney, heart, and even in placenta. They are absent in the brain. Here we can see an example of this interaction. As you can notice, here we have an APC and a first signal, a first positive signal. The MHC presents the antigen to the T cell. It was the first signal. Then we must have a second one, and the most common is CD28 and CD80. However, we recently discovered there are many signals that tries to modulate the inflammatory activity. So what were the objectives of our work? Was to identify the presence of those called PD-1, PD-L1, PD-L2, and CD8 in the tumor microenvironment of high risk cutaneous head and neck, cutaneous squamous cell carcinoma of the head and neck territory. We also tried to establish checkpoints co-location criteria and to correlate the expression of those checkpoints and risk data defined as recurrence and overall survival. So the project was approved by the Ethics Commission for Analysis of Research in this institution, and it was also sent to the National Committee for Ethics in Research. Funds to execute this project originated from everyday expenditures of both institutions, University of São Paulo and Harvard School. We reviewed medical records of patients with high-risk head and neck cutaneous squamous cell carcinoma submitted to surgical treatment between January 2010 and December 2016. We searched for patients' ID, clinical characteristics, anatomopathological characteristics, and here we can say thickness, angiolymphatic invasion, perineal invasion, margins, lymph node, and metastasis. Outcomes like disease-free time and overall survival. We initially selected 120 cases. The pathology department at the University of São Paulo made 2 slides per case, and they were sent to the MGH for analysis. Due to technical and registration problems, we were left with 46 cases that were analyzed between 2017 and 2018. Then we performed the immunofluorescence, we deprotonized the slides, we applied the primary antibodies, the second antibodies from gold, and the tyramine magnification kits. This table shows the primary antibodies. You can see that the most common donors were rabbits. You can see the company, the catalog number, the clones used, and the concentration. Tyramine magnification colors follows as PD-L1 green, PD-L2 orange, CD8 red, PD-1 purple, and DEPI for the nucleus. Images were obtained from Zeiss epifluorescence microscope located at the Biotechnology Center at MIT. This picture here shows how the program called TissueFacts works. The program and the operator define what will be considered tissue and what will be considered artifact or tissue absence. Then the tissue diagnostic programs uses the distance of 10 micron to define location and co-location criteria. This graphic shows how the program and the operator will define what intensities of colors will be considered positive for each immune checkpoint. And then there won't be overlapping of expression. Here we have some pictures, PD-L1, CD8, PD-L2, PD-L1 and DEPI, CD8 and DEPI, PD-L2 and DEPI, PD-1 and DEPI. Here we can see all of them together in a 500 micron scale. Here, all of them together in a 20 micron scale. Absolute and relative frequencies were used for qualitative variables, the Cox regression model with statistical significance, relative risk, and CI were employed in this analysis. In an attempt to establish a connection between immune checkpoints and clinical outcomes, find as recurrence and overall survival, we use cutoff points of greater than 1%, greater than 20%, and greater than 50%, as well as the cutoff values established by the ROC curve. They were divided in 2 groups as follows. Expression of PD-1, PD-L1, PD-L2, and CD8 in their co-locations in the whole tissue, and their expression and their co-location in the CD8 tumor inflammatory lymphocyte environment, what we will call TILS. So, the most common subsites were scalp and preauricular, which corresponds to more than 50% of our sample. 76% were male, 24% were female. Ages ranged from 48 and 96 years old, with a mean of 70.39. Most common T stages were T2 and T3. Most common lymph node staging was N0. 19 patients presented with PNI, 9 patients were N positive, and 2 patients N positive. All patients with a depth greater than 2 millimeters and 59% with at least 1 centimeter. Maximum depth was 5.5 centimeters. Patients were followed for a minimum of 1 month and a max of 99. Average was 45. We've got 15 recurrences, 37.9 months in the meantime for that, 14 death, and the meantime for that was 30.07 months. This graphic shows the percentage of samples with expression of immune receptors and their collocation in the whole tissue of cutaneous squamous cell carcinoma. All samples had CD8s and 87% presented with more than 1% of the cells. PD-1 greater than 1% was present in 80.4% of the samples, PDL1 in 84.8%, and PDL2 in 47.8% of the samples. When we take a look at collocation criteria, notice that the collocation follows the less common expression immune checkpoints. Like here, we can see PD-1, PDL1, the limit was PD-1 expression. Here in PDL2, we can see the limit of PD-1, PDL2, and PD-1, PDL1, and PDL2, the limits follows the less expressed, which was PDL2 expression. When we look at TILs, 100% of the samples presented with PD-1 greater than 1% in the tumor environment inhabited by CD8s. We have PD-1, PDL1 greater than 1% in 97.8% of our samples, and PD-1, PDL2 greater than 1% in 82.6%. Again, collocation criteria follows the less expressed immune checkpoints presence. Here and here again. So, when we try to establish a relationship between classical, clinical, pathological, prognostic factors, for recurrence, the best numbers we've got were T4s, and when we try to correlate them with overall survival, as expected, the best numbers we've got were for T4s and M1s. When we tried to define the chances of recurrence and overall survival, no significant value was found for any checkpoints expression and their collocation, neither in the whole tissue nor in TILs. However, the best numbers we've got in the whole tissue was for recurrence. And those are the numbers, PD-1 greater or equal to 5.426, and PD-1, PDL1 greater or equal to 3.345%. When we take a look at TILs, the best numbers we've got were also for recurrence, PD-1 greater or equal to 49.32%, and PD-1, PDL2 greater or equal than 8.974%. Although it was not described in our manuscript, we have not found any relationship among immune checkpoints expression and their collocation and any classical clinical pathological features. So, what we saw in our work was that there was an abundant presence of immune checkpoints and their collocation in the whole tissue as well as the TIL's environment. Of course, when at the time the Nobel Prize winner Angel and his colleagues first described the presence of PD-1, a new era has begun. There has been an increase in knowledge about the interaction between immune system and tumor cells. We now know that normal tissue cells and inflammatory cells form a complex gear of interaction. This complex gear is even more complex in the tumor microenvironment, when we have exhausted CD8s and we have PD-L1 and PD-L2 expression and lower levels of interleukins promoting tumor growth and spread. So since that, many tumors have been studied and are still studied, like melanoma, lung, kidney, head and neck, breast, lymphoma, bladder, and Merkel's tumor. And we have advanced since its discovery. Here we can see the discovery of PD-1, then PD-L1 and PD-L2 discovered, its presence in the tumor microenvironment, and the use of anti-PD-1 and anti-PD-L1 with good results and promising results. Of course, some questions need to be answered, like which tumors present those immune checkpoints? Is the number of expressing cells important? Does the amount of expression in each cell matters? What's the relationship to prognosis? The relationship to classical, clinical, pathological factors, and the role of collocation patterns. Is the inflammatory phenotype important, and when do blockers work or don't? Of course, we know that usually cutaneous squamous cell carcinoma has a good prognosis, but poor outcomes are possible, and functional and aesthetic problems may occur. That's why it's important to know when tumor will be aggressive and to find another weapon besides surgery and radiotherapy is so important. As far as we know, this is the first study trying to detect the presence of PD-1, PD-L1, PD-L2, and CD8 in their simultaneous location, and who also tried to establish a relationship with prognosis. When we take a look at lead, we found some papers. This one performed a double immunofluorescence in 38 patients. They found high expression of PD-L2 and PD-1 compared to normal skin, and an even higher when PNI was present. They did not search for collocation, and they described the use of pembrolizumab in only one patient. Here we can see the results described in this manuscript. This paper, this one, studied 74 patients, and they used staining percentages, cutoff points of 0, 1 to 5, and more than 5% of cells. They found PDL expression more than 1% in 52.7% of the samples, and when greater than 5%, they found it in 39.2%. TILS was present in 77% of the samples. PD-L1 expression in more than 1% in TILS occurred in 93% of the samples, and when greater than 5% in 70.2%. They showed that PD-L1 greater than 5% had a better prognosis, maybe because of the inflammatory protective phenotype. This one established cutoff points of greater or equal than 1, 10, 25, and 50%. They studied 100 patients, 41% expressed PD-L1, and when expression was above 25%, higher chances of lymph node metastasis occurred. And they also related that with a poor differentiation status. This paper applied cutoff points of greater or equal than 1%, and when they talk about 1%, they found it in 26% of their sample, and when they looked at TILS, they found it in 60% of their sample. And when utilizing a cutoff point greater or equal than 5, 10% of the whole tissue presented with PD-L1 expression, and 43% when TILS were searched. Phase 2 paper studied 78 patients. 48 had PD-L1 status assessed. They were not able to establish an expression level of this immune receptor capable of predicting the response to an anti-PD-1 drug. However, they've got a 44% of objective response, which is quite similar to a paper published by the New England Journal of Medicine in 2018. But why does that happen? Because probably we have much more mechanisms that are important and we probably don't understand it all. So we know that cutaneous squamous cell carcinoma have high levels of new antigens due to high tumor mutational burden that induces a great variety of inflammatory cells migration, inhibits the production of cytokines and interleukins, inhibits dendritic cells migration and the ability of DC to mature into a potent T cell activator. Those cytokines and interleukins also recruit Treg cells, which after all inactivates CD4s and CD8s. Also, macrophages and neutrophils, which sometimes are the first ones to get in the inflammatory environment, also express PD-L1 and PD-L2, and they probably inhibit as well as the activity of CD8 and CD4. Besides that, different techniques to access PD-1, PD-L1, and PD-L2 expressions are used, whether through location of their expression, like cell surface, cytoplasm, or even in the peripheral blood. We can perform immunofluorescence, immunohistochemistry. The way of reading it can be different. We can do it manually or automatically. We can search for it in tubes or in the whole tissue. So those differences bring different results and cause us difficulties in establishing the presence of those expression, their level, and its relation with prognosis, outcomes, and response to new drugs. And why did we choose those cutoff points? Because most papers use 1% and 5% in several types of tumors, but we can also see, like we saw today, 10%, 20, 25, or even 50%. Because we know that head and neck, cutaneous squamous cell carcinoma, and also mucosal P16 positive are also have also an inflammatory phenotype. We wanted to see if there were very high levels of expression of those immune checkpoints, and we were based in this keynote 048. What were the limitations of our work? Final sample size for sure, and we were unable to establish the correct location within the tumor where the immune checkpoints occur. I mean, when we made the slides, it was done randomly. The criteria was the presence of tumor. We don't know whether it was taken from the central part of the tumor or if it was taken from the peripheral part of the tumor, and that might matters. We don't know. So what were the conclusions of our work? The presence of abundant inflammation was found in high-risk cutaneous neoplasms with ample CD8 expression in all samples, which were always accompanied by the presence of PD-1 expression. The simultaneous presence of PD-1, PD-L1, and PD-L2 was also frequent, and the relationship among those immune receptors and the presence of PD-1 seems clear. It was not possible to establish a relationship among the expression of those immune checkpoints and their co-location with clinical outcomes defined as recurrence and overall survival. They say that when you put your hands over John Harvard's statue's feet, you get lucky and wisdom. I guess I'm already a lucky man for the opportunities I had in my life, and I know that wisdom is a lifetime journey. Thank you very much.
Thank you very much for your presentation, rigorously within the time limits, 30 minutes and 22 seconds. And before asking the members of the board to make comments, I would like to take the prerogative, that's a difficult word to pronounce, prerogative of the presidency of this distinguished panel to interrupt a little bit and break the protocol. And I'd like to, all of us, to dedicate some seconds to grieve the unfortunate victims of these terrible pandemics around the world, especially the more than 410,000 deaths that have occurred so far in our beloved country. So I interrupt officially now for a couple of seconds for all of us to make silent inner respect, to pay some respect for the unfortunate victims of COVID-19 here in Brazil. Thank you very much. Following the order of, I won't break the protocol again now because Professor Pei, we have official protocol says that the sequence will be first the two professors from outside, yourself and Professor Bandeira. And last but not least, Professor Matos, who is from the program of post-graduation here in our department. The instruction we have is that the first to speak is the one who defended his PhD thesis later. So the protocol here is that the examiners have 30 minutes to present their questions, doubts, comments, etc. And the candidate will have 30 minutes as well to answer to them. The treatment usually is formal, but here, as we are speaking in English, which is not the native language of any of us here, I will not ask for this formal treatment, so you can have a colloquial treatment. And the two formats can be accepted. Either the first one I mentioned, so first, André will be the first examiner. He will present for 30 minutes, and then Gustavo will answer in 30 minutes, or in a dialogue fashion, in 1 hour. So the examiner will choose the way in which he or she prefer to do it. So André, you prefer the dialogue way or the formal way?
No, the formal way.
Okay,
Yes.
so you have 30 minutes now for your comments.
All right. Very much. I would not like to be emotional in this beginning, but
the ceremony that you brought us.
Just a second.
Right?
Excuse me. Eu queria pedir para o pessoal do audiovisual incluir a câmera. Nós não estamos vendo a nossa câmera. Sorry, Sarah, it's just for technical things here. Nós não estamos vendo a nós mesmos aqui nessa sala na câmera. Se vocês puderem incluir a nossa imagem, vocês estão ouvindo a gente, se vocês puderem incluir a nossa imagem, facilita bastante para nós sabermos aqui como é que está a situação. Por favor, se vocês puderem, excelente.
Yes, it was me.
Obrigado.
All right. Technical.
Your fault.
Yeah, sorry.
Sorry about that.
All right.
Sorry. Go ahead.
So, I would like to thank you, Professor Claudio, for this moment we just had to pay some respect for the victims of this pandemic, and this was a very good call. This moment that we are doing something else. We're doing a defense of a thesis, which personally for me is like a dream coming true. It went back to 2016, I think, that I was able to invite and literally came to Dr. Sarah without any presentations before and asked her, Professor Sarah, we don't have this much opportunities here in Brazil. I would like to know if we could collaborate with some study together, and she so kind accepted, and here we are 5 years later, but with a great work made through, and thank you very much. Now, Dr. Gustavo, we met like 2003, five, so almost 16 years ago. She is a friend, true friend. We made the residency together. I can only talk about he's a loyal friend, he's a good loyal friend, and this is a very touching moment for me as well. You were very bold and very courageous to accept the challenge of make this presentation in English, and you have to have some credits for that. Well, spoken this, I would like to make some comments, some technical comments about the whole work, and finally, I would like to leave a little some questions for you to answer us. First, talking about your presentation, you have a good didactic. I don't know if this is the right word, but it's to explain such a difficult and complex point that all the immune checkpoints involved. There was in your presentation 15 minutes until the results, which is, I think, is a very good, balanced presentation. You finished it just on time. This was very nice as well. You have the domain of the class that you brought us. It's noteworthy, the beautiful pictures of all the stainings. I would like a comment of you when you present the thesis. There is only one case that was made all the stainings. You should probably make a comment on that. when we talk about the work, the written work that was brought us, I am addressing the Portuguese version of it. I would like to thanking department, thanking section, the reminding of my name. It was very kind of you. When we look at the texting, it was a very easy reading text. The didactic, as well as in the class, it was very, very okay. There are some things I would like to mention. In the abstract, there are two little typing problems, probably in the copy-paste word, in the Word program, there was some mistakes. In the page 4 of the Portuguese version, there is a problem, I think, when you mention the bowel disease as pre-tumoral, even pre-neoplastic. You may not talk this as in these terms, I think. Your objectives were clear. You have to identify the markers that were listed in the introduction. The collocation, which is a part of the Professor Sarah's opinion and experience in this type of research. And finally, what we planned just in the beginning, the prognosis that these markers would bring us. When we start the review of the literature, it was concise, it was very well written as well. I would like to mention the Appendix C in the Portuguese version that bring us some problems in the staging. Staging T3 and 1M0 was in two categories, so it's something that we should correct. In the page 19, at least in the Portuguese version, there is sorry about my English. There is a picture which was not translated to Portuguese. It was good to have it beautifully translated. I would like to ask you, like in general, to talk about the difficulties that you had when to visiting Professor Sarah, visiting Harvard, and looking at the process there, looking at the difficulties that we as surgeons, we are not familiarized with the environment of research in the lab. Some of us are, but at least I am not. I think you're not too. I would like you to mention the cost estimates in this process. I think that we could not perform such research here in São Paulo and even in Brazil. It's something that it's unique from a foreign contribution like your work. When we look at the results, we have to look at the prognostic effects and prognostic findings that we had. And it is based on 46 cases which seems small to look for a prognostic conclusion, a prognostic discussion, at least. But anyway, there are some things that I would like to mention. We had like a p-value of 0.39 referring to depth of invasion, 0.26 for perineural invasion as a p-value related to prognosis. It's interesting to notice that even in advanced case that we operated here, the lymph node metastasis is a kind of a rare situation. Even the lymph node metastasis in a head and neck service is a rare situation. There is 37 months for recurrences as a median time, which I think is a little, how could I say, a little long in a squamous cell carcinoma prognosis. We are more used to shorter recurrences, like in the meantime. Of course, we are kind of used to the mucosal squamous cell carcinoma, which is a little shorter. When we look at the stainings, now we as surgeons are a little, how can I say it? It's a little negotiating for us to look that so many markers are possible. We had 80% of PD1, 47% of PD2, 100% of CD8 is related to the inflammatory process. And there are the collocations. 47% of PD-L1 and PD-L2, 100% of CD8 and PD-1. The collocation of CD8, PD-1, and PD-L1 comes to 97%, which is a very high percentage. I think that probably only one case it is not presented that as together any markers. CD8, PD-1, and PD-L2 of 82%. And then the things that we had the better, the most discriminable cutoff of prognosis, which is for the collocation of PD-1, PTL1 above 3.345, that we almost get a p value below 0.05. When we look at this as a whole thing, it's occurred to me that we are kind of in the like we are discovering the effects of the aspirin, like we are the acid acetylsalicylic when it was discovered, the substance. People started to look at the effects of it, but they didn't know what was the molecular effect of this. It was only described so many decades later. Do you think that we are in this process, like we found the medication, the researchers found a medication, we started to use it, and then when we look to the tumors to look for the molecular environment, to look for the markers does not show us that response that we would expect. So, are we looking only for the surface? Are we very much away from knowing these answers? I think it was a nice thing to ask you and to listen to you about this. Well, finally, a new era has begun. Was a very nice phrase for your discussion, and thank God that a new era has begun. We have in the head and neck department so many patients that suffer with skin cancer, which is like a paradox. The dermatology and the plastic surgery departments, they are able to treat like 90–95% of the patients with success. And then when we have some problems with these smaller, let's say, procedures like dermatologic procedures, when it goes wrong, when it goes ugly, then they come to us and we have to perform some big surgeries like you shown, like you perform in Santa Catarina. And this is a kind of a forgotten population of the whole process of skin cancer. Skin cancer is a okay disease. No, it's not. There are some people who really suffers and really dies of it. So a new era has begun. Thank God we have immunotherapy, and we must understand it a little more. Finally, for some personal questions, which were not related to this work, I'd like to know your future after this PhD, like in academic works that you have. Are you looking for be a head and neck teacher at your location? Are you planning to move here to be a professor with us? I would like some opinion of you among other general things. First, what is your personal opinion about the future of the specialty? What do you think of us as a head and neck surgeon? We look for these promising drugs coming through. Are we going to be out of job? Are we going to change our way to see things? Are we going to make only smaller procedures? What's your opinion? The second question in this matter. What will be the importance of skin cancer in our specialty? Because since we graduated from the residency, we looked at the more and more radio and chemotherapy, now immunotherapy, are replacing big procedures, which is a good thing. But we are still surgeons. We're not radiotherapists, we're not radio-oncologists, we're not clinical oncologists. I'd like to know what's your opinion on that. Third, what do you think, what's your opinion on the future of healthcare? First, in Brazil, linked to neoplasia treatment, we have some upscaling costs, and we are not rich as a country, where people, probably the world is not as rich as the neoplasia treatment seems to be, like the cost is going to be so progressively high. First for neoplasia treatment, and then for the health care as a whole. And the last question that I would like to leave you, and with this I finish my kind of long talk, the future of the immunocheckpoint research. We're going to know more and more about this. This is going to change for another subject. We looked in the last year how the funding for vaccines and things was absolutely focused on this matter, and I don't know if we are going to have a similar time of the funding to this kind of disease. Are we going to have so much funding for research, like for neoplasia as well, or are we going to change a little? I think that's pretty much it. I would like to thank Professor Claudio to help us in this, being the orientator of this whole work. I feel like a part of it. I feel like something that we made together, and this is a very, like I said, an emotional moment for me. So thank you very much, Gustavo.
Thank you so much, André. You are certainly a very important part of not only of this work, but also of the whole service here. And it has been a privilege to work with you all of these years. So,
Okay.
the candidate has 30 minutes, up to 30 minutes to answer.
Well, I'll try to answer all the questions. Please tell me if I forgot something. Mm-hmm. You helped me a lot. You are friends, and I will always be grateful because the experience I lived was priceless in my life. I had, like I said, I consider myself already a lucky man because I had those opportunities, and that's very nice. When we talk about the challenge of making my defense in English, at the beginning, I was thrilled, but obviously afraid. And after thinking a little bit, I said, no, not a chance. But then the university didn't allow me to make a translation, simultaneous translation. So, and my family and my wife have supported me in that. And I said, Professor Claudio one day told me, I'm here with everybody, and they say, you must do it in English, and otherwise we won't have Sarah. And I said, no, Sarah must participate in that. I will thank you, Professor Sarah, again, and I will talk about it a little bit later. So it was a great challenge, and I'm happy that I did it. I noticed those abstracts mistakes after I delivered the final version, and I said, well, I'll make a correction later. It's not too late. And Professor Cernay is written in the abstracts, and I'm sure it was a mistake from the printing group. Of course, bullying is already a cancer. It's not infiltrative, but it's cancer. It was a mistake, as well as the T3N1. They obviously cannot belong to the same different staging. So that will be corrected. When we talk about the cases, the pictures, and we are talking about the case 17, And those pictures were taken and they were sent for me as the best cases, the most beautiful immunofluorescence images that we had. So that's why we picked them. And that's it. That's the only reason for that. Okay. When we talk about my visiting to Professor Sarapay's lab, which I did twice, it was an amazing experience. I know that Professor Sara is a surgeon, a head and neck surgeon, and dedicates lots of her time in research now. And it's a very nice place to be. I learned a lot with basic science. You know, we live in Brazil, and it's very difficult to do basic science. We all know that. And our jobs here are not, of course, for the biggest institutions, they have it, but they don't have like a contract that we must do assistential work and research and teaching. Unless you work for a university or a big institution, it's not possible. So most of my time is in my office and operating, and I depend on that for living, and that makes it very difficult. So that's an issue, I think, for Brazilian science. You asked me about costs. I'm not sure, okay, but it seemed expensive for me. And sometimes when I talked to the biochemistry people and the support people at Sara's lab, and they talked about how much all of that costs, and I don't know. I wonder if it was about $200,000. That's a guess, but it's a guess, okay? So I really do not know. You asked me about the collocation criteria. And one of the most difficult things to understand for me was the collocation criteria. And to understand, and now I'm for sure that they're actually together. When you take 10 micron distance from the nuclei, from ZAPI, which is first described in 1971 as a drug against protozoan, and then they discovered that DAPI could transpass the cell membrane and has a great affinity for some nuclei DNA structures. Then I realized that they are always side by side, and that is a collocation criteria. And when I looked at the table of each case, I saw that those immune checkpoint expressions are really together. I mean, they only exist when one exists. I mean, like if you have PD-1 in one sample, at least 80–90% of them are linked to whether PD-1 or PD-L2. So they only exist together. That's my final understanding about that. Okay. About my future, I think I was a pathfinder in my city. I was the first head and neck surgeon in the place I live that now have almost 1 million people living there, and now we have a team of five. So I'm kind of happy with that, and of course trying to start science in a small town is much more difficult. So the experience of this PhD was amazing, and I'll try to live it to the city I live and try to maybe start something, because knowledge now needs to be everywhere. About the future of head and neck, I had the opportunity to go to the PTA Salpêtrière 2 years ago to do in a week of part of the university here agreement, and I spent a week there, and I heard people talking about genetic therapy and using adenovirus and salmonella, and we have, of course, immunoblockers. And at the last day, I raised my hand in my awful French, and I asked him if I should think of retirement. And he said, not now, but for sure, it will happen someday. I don't know for skin cancers, because I think skin cancer surgery will always be cheaper, especially if it's not a very aggressive or huge tumors, and especially for poor countries, surgery will always be cheaper than those drugs. So I think that skin cancer will continue to be operated for a long time. And those immune checkpoint blockers, for sure they work. Like I told you, I had read 2 papers and that found almost 50% of response. That's a lot. And they work, especially when they are huge tumors. And what is lacking? What's absent? I remember talking to Sarah once, and she wanted to search for FOXP3. I don't know if she remembers that. And she wanted to search for Tregs in cutaneous squamous cell carcinoma. And when we read it, and some time ago I read about macrophages and neutrophils, which I did not know that expressed PD-L1 and PD-L2. So there are more interaction, and the sum of those interactions are not yet fully understood. So that's, I think, that's the future. When we talk about healthcare, I guess we'll have, I hope I'm wrong, but the future of healthcare, especially in poor countries like Brazil, will be different. It is already different for those who have money and for those who don't. So there will be 2 opposites, totally different medicines. And I think that's, unfortunately, is the future. I think there is no money enough for immune blockers. When you take a look at rheumatology, tumor, and I know I'm sure we will treat like antibiotics will be genetic therapy. We will introduce an adenovirus that will delay or suppress the transcription of beta-lactamases. That's the future, I think, but it will be expensive, and I don't know if it will be for everyone. I think that's pretty much what you answered, what you asked me for, and the expression, and it's amazing how huge immune checkpoint expression is in the tumor inflammatory lymphocyte environment. Huge, it's there, yeah, and it's a lot, especially CD8s. I think that's it.
Are we looking at the surface of it? Is there much more? It was one of the questions that I asked. Are we looking just for the surface? Is there a lot of
the tip of the iceberg?
Yes. Are we not understanding anything at all?
Not in the cell, but in the whole tumor.
Yes. Oh, we have a drug that we don't know all the interactions, how deep we are.
That's a tough question. That's a very tough one.
He's your friend, huh?
Yeah. And I think we are not able to answer that yet. Maybe, I don't know. Like I said, we can search for it in the peripheral blood or in cytoplasm. And like one of the limitations of our study, like I said, when we made the slides, we don't know if it was taken from the peripheral part of the tumor or in the central, or does it matter at all, after all, or it doesn't, right? So that's one question that we might answer eventually.
Okay, I'm satisfied.
Thank you very much. Are you satisfied with the?
Yes.
Okay. Thank you for sticking to the time limits. So before I call the second examiner, Professor Pei, I'll take the prerogative as president of this panel, this board, to explain to Professor Pei. Here in Brazil, I don't know if you are aware of what was discussed here about public medicine, etc. Brazil is one of the few countries in the world that has a system that obviously works with laws, etc., mainly due to the economical situation in general and specifically now in the pandemics. But for technical and political reasons that I prefer not to discuss right here, this system actually is considered a universal system for healthcare. So meaning that the whole population has some kind of medical assistance. This does not happen in all countries, including the United States. You know that very well. There are nearly 100 million people in the United States that have no kind of public health assistance whatsoever. They rely upon some clinics, some hospitals, etc. So this is not the case here in Brazil. This is a victory of many governments before, and with all the flaws, I'd like to emphasize that, and with all the problems we are facing right now because of the pandemics, is still a quite effective system because the whole population has the right to be attended, has the right to be seen. Just to clarify to Professor Pei. So the second examiner will be my dear friend, Professor Sarah Pei, and I cannot thank you enough for your acceptance to participate in this different ceremony here. Different in all senses. Number one, because of these crazy times we are facing right now. It's odd. His family should be here in person, in a theater, like all the. He's my 10th mentee for doctoral thesis, and the previous 9, all of them. We had a family, we had several people watching, and after that there was this dinner or this party, etc., etc., etc. So like everything in these crazy times, we are present in spirit, but not in flesh. So this is one. Number two, we are having, and this is very good, we are having, and that's a first for this department, a presentation and the board examination for the candidate in English. And this is a first. And this is very important for the postgraduate service of the department here, because this is part of the process of getting international. And obviously the language all over the world is English, and this is the very first time that such a thesis is presented and examined and criticized in English here. And I'm very, very happy that you are the pioneer here with us with all our limited English communication and being part of that. So I cannot thank you enough for your kindness. For those who are watching, I hope they are understanding our English here, Professor Pei is a sweet person. She's a terrific head and neck surgeon. And last but not least, she is a world-class scientist. It's not a coincidence that now she has one of the busiest laboratories in head and neck oncology, not only within the limits of Harvard, but I would say within the United States and all over the world. So it's a true privilege for this medical school to have you here as one of our examiners. Having said that, you have 30 minutes, and I will be very rigid as usual. So I am starting your clock right now. Do you prefer to make dialogue, or you prefer 30 minutes, 30 minutes? What do you prefer? It's up to you.
Yeah, I think dialogue would be great.
Perfect.
Yeah.
So you have 1 hour then.
Okay.
Up to 1 hour, of course.
Well,
Please feel free.
yeah. Well, thank you, Claudio. I think this relationship between Mass General, Harvard Medical School, and University of Sao Paulo speaks to your strengths about creating bridges across communities. And so really appreciate the opportunity to participate in such an important event, such as a PhD thesis, committee. So first, also, I want to thank the group for speaking in English. Gus, you did a fantastic job. You would think that English was your first language, so kudos to you for doing that. Also, I want to just highlight, what a great supportive mentors that you have in Claudio and Andrea. That's so important in anyone's career and successes. So I echo how fortunate you are to be able to have that support system. Also, so I wrote some notes down. I want to just highlight, I think that the work that you're presenting is so timely. You were looking at these markers before anti-PD-1 was approved in cutaneous squamous cell carcinoma. And so one of the goals of the work was to provide the data to support that these drugs would be effective in cutaneous squamous cell carcinoma. And I think that as you were doing the work, the field is moving so quickly that, now today in 2021, we have 2 drugs of anti-PD-1, which is approved in the United States for cutaneous squamous cell cancer. So again, the fact that you were able to participate and be part of this important change in care highlights the importance of your PhD thesis work. The other thing I want to just highlight, which may not have been so obvious in your presentation, is as part of the PhD thesis journey, it's always being able to troubleshoot and overcome barriers to the success of the research. And there were a lot of barriers. Just even getting the tissue out of Brazil took over a year to get all of the approvals, And then in addition to that, the preservation of some of the tissue didn't facilitate for some of the immunostaining, which decreased the number of samples which could be stained. And so, again, that shows being able to overcome and continue to proceed with the work without being too discouraged to just give up. So again, I think that's part of the PhD thesis journey, which you accomplished during your time. So anti-PD-1 therapy targets the PD-1, PD-L1 axis. And the two anti-PD-1 therapies approved for cutaneous squamous cell, which is pembrolizumab and ipilimumab, they do not have a companion diagnostic for PD-L1 testing. So, what do you think that may imply? And two, based on the biology of cutaneous squamous cell carcinoma being UV induced, can you think of, well, what would be, taking your work, what would be some potential ways to then, what are the next steps to expand upon your work?
Well, first of all, for the first question, it's like I said, it's difficult to say whether the drug will work or not, only based on PD-L1 expression. When we take a look at papers, most of them only search for PD-L1, and one of the issues that we might have is that we can have PD-L2 as well, and so it doesn't. If you have an absence of PD-L1 assessed, it doesn't tell us that the drug will not work. The second thing is that, as far as I understood all this process, is that sometimes the PD-L1, it might be protective. I've read some papers that try to separate the presence of inflammatory phenotype as a protective matter, and then you have to separate if it has an inflammatory phenotype or not, it's a protective one, and if in the inflammatory phenotype, if it's positive, then the PD-L1 presence might be a concern of worse prognosis. Those papers were done for P16 positive mucosal head and neck squamous cell carcinoma, and they're kind of similar. So we might think that it may be much more complex than that. Like I said, if you have neutrophils or macrophages, they can be a balance, and simply the presence of PD-L1 is not enough to determine whether the drug will work or not. I don't know if I answered the first question. The second question, which is, what's the future of that? And that's more difficult to answer. And we know for sure that UV radiation exposure promotes a high volume of mutational burden, like I said, and it promotes a high production of antigenes. So we might have more things to deal with. I mean, maybe we should use anti-tumor growth factors along with anti-PD-1. It might help. I mean, we can have combined therapy against cytokines and interleukins. That might work. I think that might be a strategy, like a combined therapy, like we already use for melanoma as well. I think that might be important.
Yeah. So I agree. The fact that PD-L1 is not requirement for anti-PD-1 therapy for cutaneous squamous cell carcinoma suggests that PD-L1 may not be the best biomarker to predict response to that therapy. And so trying to look for other potential biomarkers of response. And just like you said, because these are UV-induced cancers with a high tumor mutational burden, could it be that the mutational burden, high tumors, might actually be a better biomarker of response? So that's true for colorectal cancers. So another potential next step for the next person who might be interested in or continuing this work is to see if tumor mutational burden can predict response to anti-PD-1 therapy. You've done the PD-1, PD-L1, and then trying to see if tumor mutational burden might be a predictor of response. Now, the other thing that you touched upon was the combinatorial strategies, which is what the field is going into. Now people are going beyond just giving single agent anti-PD-1. And in Brazil, what struck me was the fact that you guys were taking out these large tumors. And if anti-PD-1 is approved in Brazil, there might be an opportunity that's unique to your group to be able to do serial biopsies while the patients are receiving anti-PD-1 to see what biomarkers might be present that predicts response or not. So that is an area which is going to be unique for your group to be able to do, because in the United States, cutaneous squamous cell carcinomas are too small to be doing serial biopsies on. So that might be, an opportunity that you guys may want to explore. Also, I just want to say that just want to highlight how impressed I am with your group to again be promoting surgeon scientists, given the high clinical demands currently in the medical field, with increasing the increasing push to see more patients in the limited time with lower reimbursements. And it's important because I think discovery tissue sample biopsies is where the surgeons can really make an impact. So, whatever we can do to try to support those efforts at University of Sao Paulo or Catarina, we're all eager to participate and help with that vision. And we would welcome any additional residents or junior faculty from Brazil who are interested to continue the relationship with Mass General, Harvard Medical School, because I think that there's real opportunity to be able to synergize between your strengths and some of our strengths that we would be able to really make an impact in the head and neck cancer oncology arena.
Nice. That's amazing to hear. That's great news, because that partnership between those institutions, and because we have so many big tumors here, might provide the material that we need and you need to make these go forward. That's amazing. That's something that we are looking forward to doing it, right? Right?
If I may break the protocol again and make a comment here, a side comment, I think this would be very nice, and in the case he will be approved in about a couple of hours here, maybe he will be wondering if he's going to go back there to study as a postdoctoral, eventually as a full professorship thesis, a development of that, which, by the way, was exactly what happened with one of the examiners here, Professor Medina. He did a doctoral thesis in skin, in lip cancer, and a full professorship thesis in lip cancer as well, but in a much deeper level, and both of them were brilliant. So I think this is very good that you offered this to us, Professor Pei, because actually we have a strong link. I told you that one of our residents here, who actually was resident together with this Andre Potenza, was a clinical fellow with Greg Randall for 1 year already. So there is a strong link between the two institutions, the two departments, and I will submit to my chief, Professor Kowalski, who is presently the chairman of our department, and I'm sure he will be more than glad to further develop this in a much higher level than already it is. So sorry for the interruption, the intermission here actually, but please go ahead.
Yeah.
You still have time if you want.
Those were all my comments. Those were my comments. Yeah. I think you did a great job, Gus. Based on all of the challenges, and you really did a really nice job. You didn't have a lot of immunology background, but the process, this journey, I could see the growth in your knowledge base of immunology and immuno-oncology. So.
Thank you, Sarah. For like I said, for us as surgeons, it's very difficult to learn that later, and it was a great pleasure to be twice at your lab and to learn a lot and to hear you and to see you guys discussing what was the strategy that it will be used, the timing for that, and how a high quality lab works. And it was a lifetime experience, and it demands dedication for sure. And why not? Maybe a postdoc if you accept me sometime.
And I will be glad to be your mentee for the postdoc as well. And eventually you can offer him a job in your lab. We could move to Boston. Well, I didn't say anything. Okay, you are satisfied with his answers? Okay. Thank you so much, Professor Pei. Let me go back to the beginning here. And last but not least, and Professor Medina, I will break the protocol once again after Professor Matos speaks, so please stay on, okay? Don't move. Stay there. Thank you. We have the pleasure to have Professor Leandro Matos here. I talked a little bit about his impressive CV. Albeit being so young, he is already first-class, a world-class researcher. His doctoral thesis, his PhD thesis, was chosen in 2014 as the best oral presentation at the largest international meeting in head and neck oncology so far. In the New York meeting of the International Federation, there were like 3,700 attendees, and his doctoral thesis received the first prize, the first award, as the best paper in research in the world at that year. So this is a good portrait of the fantastic capability of this young doctor, professor, and researcher. He's so energetic that I would say that even, what's the name of that runner who was world class in 100 meters? Usain Bolt. I think that even Usain Bolt will have some difficulties in keeping pace with this young professor. So it's a privilege to be here with you, to have you in this board. And for those who don't know, he's also a professor in statistics, not only a medical doctor, but also a professor in statistics. So thank you so much for accepting the invitation of the department to be the examiner here. And you have, like everyone else, 30 minutes. You prefer dialogue or you prefer 2 sessions?
Dialogue, if you don't mind.
Okay, so time is on.
And thank you, Professor Cernea. Today I discovered that you are protocol broker and also a liar about everything that you told about me. Thank you. And Gustavo, first of all, I'd like to thank you and Professor Cernea for this kind invitation. It was a great honor to me to be here and to participate on your thesis. I'm very glad to be here. And also, as Professor Claudio said, Dr. Pei, and also Dr. Santos, I would like to congratulate you again about to accept this challenge to present your thesis in English. To be here is not easy, and to be here speaking English is much more difficult, I think. So, as the last one, the other members already turned my job really easier. So I will just focus on some major questions, and in like to have a better thesis at the end of this process. And first, I love your class. It was light and clear. Andrea already told you about the pictures. They were really beautiful and really easy to understand this complex model that is the immune system related to tumors. Just one point that I want to address is that you just committed a little excess of reading, but it's absolutely comprehensible due to this problem with the English language, and it's okay for me. I read that your thesis just in English, so my considerations will be about this version of the manuscript, only this document that I had access to do these considerations. I found some English mistakes, but not too much. I will send you a version, a commented version of the document for corrections to the listed versions for to our library, okay? And I'd like also to congratulate you for the epigraphy and acknowledgements. We know that a scientific study and a research as main point is not a work of just one person. We have a lot of people that help us to make this study possible. So congratulations for that. Just some minor points about formats. There is a mistake in the number of tables. I will send you this in advance. Don't worry about that. And I like here to stop for a major point in my opinion. I understood clearly the difficulty to establish a cutoff point of PD-1 and other ligands, this expression. Sometimes it was a little bit confusing to me about so many numbers. So 1%, the rock curve cutoff point, 5%, 20%, 50%. Sometimes you could see the confidence interval that was really large because the small sample. So in my opinion, for the paper, I think here you can also demonstrate all your results, but for the paper, I think you have to choose just one because it should be confusing for the reviewers to understand the relevance of your results. You can interrupt me anytime that you want. Don't worry. So that's it. When I read the abstract, I was thinking, let's reduce this to more focus on the main question. Okay. The introduction. Okay, go ahead. Go ahead, Gustavo.
Okay. First, thank you for accepting our invitation, and thank you for the help in the statistics, which is important. And I think that's a great issue because, as you said, so many variables makes it difficult to prove anything. What I think is maybe we should maybe divide them on PD1, PDL1, because collocation is an important subject here, because as far as I searched in the lead review, I did not find any of that, or not all of that. So we might use different strategy, because I believe this work deserves to be published, and it has all that takes. And like Professor Sarah said, it's a great subject nowadays. It's been used. There are some papers going on, not only as a second-line treatment, but also as a concomitant post-surgery treatment study that's been around. So there is a lot to go now, and maybe we should think about different strategy that we could make this work to be published. Maybe PD1 and PDL1, or maybe PD1 and PDL2. I remember that Dr. Sarapé was very interested in PDL2 at the time. So maybe we should discuss more and try to find better results with fewer immune checkpoints, fewer variables. Maybe that's a valuable strategy. I don't know.
Okay, that's not right answer to this question. It's just to discuss, but this is a critical point in my point of view to better establish a publication target. I read the introduction also and the literature review. Some people don't want to read the literature review, but the introduction, in my opinion, needs a little bit of focus on the main question of your thesis. So I could not get a real link between immune system and cutaneous squamous cell carcinoma only by the introduction. So I think that 2 or 3 paragraphs at the end of the introduction making this link will turn the introduction better. Then to the objectives, I think they are correct. Just the second one is page 21 of the PDF. I don't know the page of the thesis. Let me check here quickly. Is 30, sorry. Page, oops, 7. The second point, 7. The second point of the objective, the word criteria for me is not clear. Because when you look your conclusion for this point, I think presence could be better, or I don't know, another word. Because when you talk about criteria, it looks like for me that you are looking for a method of detection, and it's not the point. You are looking for the colocalization, the expression itself. So I think this word is not okay.
And it's written as well in Portuguese like that. I will correct that. Okay.
Okay, good. Just a suggestion to make it clear, but they are symmetric. When I read the objectives and the conclusions, they are symmetric. This is methodologically correct. In methods, as André already said, the pictures are amazing. They are absolutely beautiful. So, in your class here this afternoon, we get a better explanation about all of them. I think the legends of these figures are a little bit poor. More information or at the paragraph establishing better these expressions could be easier to understand. Sometimes, it's good to see PD1 is like a green, for example, is purple. This helps us a lot to understand the results. But in methods, we cannot see this link. When you write about the reagents Alexa color 400 and something, you don't say PD1 is green or PD1 is purple and etc. So in sometimes I think that a better explanation could be better. And also this case, I think it's case 17. It's a case with a very high expression, right?
Yes.
So I think a comment about that should be good. So we select a patient with very high expression in order to better show this result, and that's it. Something like that. Because when I saw that, I imagine, oh, if everybody has this expression, 1% could not be the cutoff, because the expression is absolutely high and disseminated at the tissue. So this case, I think, is an outlier, maybe. So I think this point should be clearly stated at this as an example, just thing like that.
Okay.
And I'm just curious about something. I don't know if you could address this to me. Immunofluorescence in paraffin tissues, it's not easy to perform because paraffin has an autofluorescence. Do you know how autofluorescence was controlled during the assay? Just for curious, if you don't know, no problem. Because I worked with immunofluorescence before, and we have a very high background, like a blue background, not about DAPI expression, but for paraffin expression. Do you know about this process?
I don't know if I catch your question. I was at Professor Sarapei lab during the whole process. I was with the biochemist all the way with deprofenation, and it's a long process. You have to apply lots of alcoholic substances and then let it rest for 24 hours, and then you apply the antibodies and the second antibodies, and then the pyramid magnification kit. So it's a very long process, and it takes time, and the reading of this material is also very complex. I was amazed by the time I was there, and I saw what the microscope did. They mapped the whole slide, and there is the program itself makes differentiates from all ranges of colors and overlapping. It's amazing, and it was all automatics, but it takes lots of time. I don't know if it's what you were asking me, but the impression I did is, yes, it's lots of work. It took time. I was there 2 times, and I saw how difficult and how the process can be wrong if it's not done correctly.
Okay, good, thank you. And just to end about the methods, I'd like to ask you about the statistics, the statistical analysis, because we choose the Cox regression model for univariate analysis, and if we could go further for multivariate analysis. And when we use Cox regression model, the associate variable here is not relative risk, is hazard ratio, because survival is a time-dependent endpoint. So I think the analyses are correct, but the name of this association variable is wrong in the entire test. You have to write hazard ratio.
Okay.
Okay. And also in the methods, the Kaplan-Meier curves and log rank tests are missing. I will talk about this a little bit later. The results, in my opinion, they are good, but I'd like to just to talk with you about something André already told us about these marginal values of p-values. Take care in order to do not perform any inference or any adjective about it. Sometimes we are excited about the results. Is a result with a promising variable, for example, is not methodological correct to write about it. You can do it at the discussion, but not at the results. When you saw, for example, a p-value of 0.091 in a sample, it is not statistically relevant. So you cannot say a promising variable or the more statistically variable. They are not statistically significant when we adopt the cutoff of for p-value. Okay.
Okay.
And just a major point that I think you have to correct here in the thesis. For example, in page 43, when you put the Kaplan-Meier curves, you put the p-value of the Cox regression model. This p-value is not correct. You have to use the p-value of the comparison between the curves, not the p-value of the Cox regression model. So when I see, for example, let me check graph 6, or better, let me check a better one. Graph 8, for example, or graph 7, page 48. The curves are absolutely different. I can affirm certainly that this p-value is not correct, because the p-value here should be much lower than this one. So you will have to correct it for the log rank test. That's correct test to compare both curves. Okay.
Okay.
And two other points. The discussion should focus on the comparisons of your results with the literature. Sometimes the discussion talks about some literature review, for example. I just signed everything to you. I don't think the thesis could be correct in this point, but for the paper, I think we have to focus on it, and also to better discuss the limitations of the study. Okay.
Okay.
And a document that in my point is not correct is the IRB approval. You put the approval of the CONEP, that is our National Ethics Committee that goes further for studies, multidisciplinary studies, multi-institutional studies with other countries. But the final response of the CONEP was sending back the submission to our IRB. So I have to put the final approval of our IRB in order to your thesis be ready to go to publication in our library. This is absolutely fundamental. Okay.
I have a print here because we have noticed that, and I have even printed that to make sure that, and I will correct it. Yeah, we've noticed that later it will be corrected.
Okay. And I'd like just to ask you for two philosophical questions here. What is your opinion about this target, the target's co-localization in immunofluorescence assays? Do you think those molecules are really together, or they are just one besides each other?
I think they're really close to each other, and I discussed that with the lab technician, not only at Professor Sara's lab, but also we talked about it with the technician that was operating and analyzing those collocation patterns at the MIT, at the epifluorescence microscope, and what he said was they're very close. They're 10 micron distance. So what appears to me is that they only exist together. They're not thrown in the air by themselves. There's probably, I think, and that's an induction of expression of an immune checkpoint, maybe after a first signal is targeted, and it induces the expression of PD-1 or PD-L1 or PD-L2 in the cells. So that's why it looked to me. I think they're very close.
Yeah, because when we study immunofluorescence, for us, the molecules are together. But when we write about it, we have to say that they are close. So this is some tricky, but that's it. I think the explanation was good. And the last point here, and I think this should be better go to the discussion of the paper. We are talking about 1% as cutoff. 1% is not high. Oh, really? Okay, but 1% is something little. But sometimes, this is the cutoff of the literature. Dr. Pei properly said that this target therapies does not need to be checked by the molecular targets, etc. But 1% is a low expression. And sometimes at the test, we read about high expression. I think we have high number of patients with more than 1% expression, not really high expression, because 1.2% is a very low expression, but we have a lot of patients that express more than 1%. So I think this should be clear in some points, because the cutoff is very low. Okay.
I was actually yesterday I was thinking about it, and I was thinking about especially CD8, and I was thinking, well, is 1% of CD8 expression a high volume or a low volume? Because if you look at the high density of a tumor presence and the presence of those tumor cells, maybe 1% is not a small number of CD8 presence. Maybe it's a lot for the immune system. I don't know, and I have not read about it. And but if you have each 100 cells, if you have one CD8 cell in the tumor microenvironment, of course it looks like a lost battle, but it's not. But there are soldiers that, and that's not a field for immune system. And like I said, maybe if we take a look at the peripheral part, like when we do margins, when we analyze the margins of a tumor, and you talk to the pathologist, and he says, well, we have lots of inflammatory cells here, and they are also always in the peripheral part of the tumor, and they tend to consider it like positive margins when they see inflammatory cells. Maybe 1% in the central part of the tumor might be a lot, but that's an object of thinking. I agree with you. Lots of samples were positive for more than 1%, but is it a high volume or not? Maybe not. 1% seems a few, but when you think about it, maybe it's not that small number. I don't know.
No, sure, sure. Nice discussion. Please write it at the manuscript, okay? Because this is the point. We don't know about these things, and we should write about it to better understand this in the future, I think. And that's it. I think they are the major points I addressed here. I will send this corrected version to you to further corrections. And again, I'm really happy to be here. I will go downstairs to deliberate with you, okay?
Anything else?
No, thank you. I guess that's been a great opportunity, and thank you for all the board to be here and to.
I mean, excuse me. Anything specifically related to?
No, I think I'm good.
Okay. So, two things. First, as I said, I am the mentee of this thesis, and I like to make clear that all the qualities and all the value of this, my opinion, obviously I am biased, but in my opinion, outstanding work belong to him. The other thing, I'd like to emphasize that all the flaws are on me. So please, make this clear-cut distinction when you decide about the true value of this particular work. Number two, again, Leandro, I'm sorry to disappoint you, but I'm going to break the protocol again. As the former speakers, former examiners, and the candidate himself were very generous, allowing us time because we could stay here easily until 8 p.m., 9 p.m. We won't, don't worry. But they allowed us, you allowed us to have some extra time. So it's not usual, Professor Pei, to have a standby examiner standing on the bench and not opening the mouth at all, like Professor Medina is doing right now here, for the whole length of this exam. So I'd like to break the protocol again, sorry Leandro, and to offer off record about 15 to 30 minutes for him to make his comments. This is off the record because officially I can put only the three examiners who are here, but off the record for our hearts, not for the paper, but for our hearts, I'd like to hear your comments, and I'm sure the candidate, I didn't ask him about that, but as a president, I decided. So I am sure he is eager to hear all the comments and all the questions you have. I'm going to give you half time, not 1 hour, but up to 30 minutes if you will. So please. Feel free.
You are asking me?
Yes, I'm asking you to make comments and questions, if you will. I don't want to embarrass you, please. Feel free.
No. I didn't know if is there any other of the backup members with you in the room. Okay. So thank you, Claudio, so much for this excellent opportunity to express my happiness to be seeing the work of Gustavo Bento in order to get his degree, his PhD degree in our fabulous School of Medicine. Thank you. I have to thank also the post-graduation department in order for thinking in my name, in my indication to be in this board. So it was also an honor for me to be the Professor Pei backup in this judgment, in this defense of the thesis. So thank you so much for this opportunity. Well, Gustavo and I, we worked together since he came back from his residence in São Paulo, in our Hospital das Clínicas. And then we have participated in many surgeries together, and I had the honor to have him working, attending me in the surgeries, and until the year of 2013, we have been together. After this, he decided to move to another city, and then we have lost this opportunity to operate on these difficult cases together. But I've seen and I know that he's a famous doctor in that other city, and they are making a very nice team in order to treat these head and neck patients. I've learned, I have the opportunity to learn many things in reading the thesis, and I agree there is some things to just polite, and then the work will be for sure very successful. I personally think that the future of the treatment of the squamous cell carcinoma, cutaneous squamous cell carcinoma, will have the immunotherapy as a good presence and a very nice way to treat. This will happen. I hope that I can stay alive in order to see this happen in some years. And to choose this issue, I think it was a very nice option from Gustavo, because a part of we cannot cut as a surgeon or as surgeons, we cannot cut PD1, PDL1. We have to study it so hard in order to achieve the potential way in order to treat. So I just have the having this opportunity give me from Claudio. I have to congratulate the very nice presentation of your paper, Gustavo, and I think that all the comments that the other members of the board have said will just contribute to your work, and you must know that you are very successful in publishing this in the future. So I'd like very much from your last picture, Gus, because I have been in the Harvard campus many times. I really I think that in past lives or other lives I've been a Harvard study because I feel so nice, so good standing in the campus and seeing all the buildings that every time that I come that I go to Boston, I used to go to the Harvard campus. And I don't know if you are aware that the John Harvard statue has a very nice story. All the rookies, the first year students, are asking to stand up at that statue and have a pee over the statue. So careful when you put your hands in the foot because you have to know about it.
So, are you telling me I shouldn't have put my hands over to Harvard statue? Is that right?
Oh, so sorry for the joke, but it is true. One of the guides of the campus told me this, but sorry for the joke. So thank you very much for the opportunity to participate, even off-label, even off records, in your board of this thesis. Thank you so much, Claudio.
Okay, any of the examiners want to do any additional comment, want to make any questions? Please feel free. I understand that silence is a no. The candidate wants to make any comments. These are your final words. I'm sorry, not the final words of your life. The final words in this exam. So, please.
Those are my final considerations.
Yes.
It's been a great journey. All the people that are standing here participated somehow in my my life, in my formation as a physician. André was a residency colleague with me. It's been almost 15 years now. It's a lot. I had Professor Claudio, who always inspired me in studying more and being a better surgeon, and teach me what are the values of a good surgeon and a good person. And then I came back to Santa Catarina, where I met Professor Medina, with whom I had the pleasure to work for 6 years. I've been to Boston twice, and I learned a lot with Dr. Sarah Pei, who have welcomed me so well, and I will always be grateful. I've met Professor Leandro, who taught me some of statistics, who gave me some ideas, who participated at my qualification exam 2 years ago. So all of you have been very important. Of course, other people from my life, my family, my wife, my partners at work, they all made that possible. So, like I said, wisdom is a lifetime journey, and I don't plan to stop it. So maybe a postdoc, who knows. Thank you very much. It's been a challenge. Sorry, Leandro, for reading it, but I have practiced a lot, and it's very difficult not to read when you are standing in front of the panel. So if you are against it, it would be much easier not to read it, because of course I know that it slides backwards, and so, but it's difficult not to read it. It's been an experience, different with the pandemic status. I waited to defend it because I wanted all of them together. I had invited Professor Sarah to come to Brazil, but unfortunately it was not possible. So that's okay. I'm happy.
But she's here.
She's here, yeah. But you know, physical is different. Having you two here, for instance, is much better. So thank you for the opportunity.
Before we close this part, we are going to convene now just the board. We will ask the candidate to leave in 2 seconds, but before we go to that, regardless of the results, I'd like to congratulate the candidate. It has been a wonderful experience to mentor you, and to congratulate your family, especially Graziel, your wife, who is here somewhere. I don't know where exactly, but she's here around, she's in the building. Because I would say that the heaviest burden is actually not on the candidate, but on the family. Because the countless hours that you withdraw from being with them, especially with small children, as you already have.
I don't.
You don't have children. Not yet.
Yes.
Not yet. You are going to. Anyway, the family life is absolutely, you stole time to be with your lovely wife in order to travel overseas and to write this thesis, so forth and so on. So, congratulations to Graziel. And now I have to ask you to please leave this particular room. I'm going to call the people there on the phone, and please, the rest of the people stay tuned, because as soon as we reach the conclusion, you have access to the what's the name of the? No, I'm going to call to you have access to this again. So please, the members stay here, except for you.
Professor Claudio, I'm going downstairs to meet you, okay?
Okay.
Claudio. Andrea, hi. I didn't realize that this was going to go longer, but I'm chairing another call that started at 3 o'clock.
All right.
Is it
Estamos sem som.
Precisa ligar o...
Assim, é que o Cláudio estava falando um monte de bobagem.
Ah, tá bom.
A Sara já foi?
Ela precisou ir, mesmo.
Bom, em primeiro lugar, essa é a última etapa, né? E a professora Sara Pei tinha um compromisso acadêmico agora, exatamente agora. Ela pediu licença e deixou saudações para todos. E agora, obviamente, é em português o anúncio final da decisão da banca. Então, eu agradeci em nome do departamento, em meu nome pessoal, a gentileza dela ficar uma tarde inteira aqui à nossa disposição. E eu acho que isso foi um marco muito grande, realmente, que a primeira tese em inglês daqui do departamento e a primeira tese que conta com um professor de Harvard, uma professora, no caso, participando da banca. Então, eu vou ler, então, o documento final que foi produzido. Relatório da Comissão Julgadora, aos 5 de maio de 2021, atendendo ao dispositivo no regimento de pós-graduação da Universidade de São Paulo, o candidato Gustavo Nunes Bento, ao título de doutor em ciências, área de concentração de anestesiologia, que na verdade é anestesiologia, cuidados perioperatórios e ciências cirúrgicas, apresentou sua tese de doutorado com o título Expressão de PD1, PDL1, PDL2 e CD8 em carcinomas escamocelulares cutâneos de alto risco em cabeça e pescoço. Esta comissão, indicada pela Comissão de Pós-Graduação, comissão julgadora aqui, é de parecer que o candidato apresentou sua tese de doutorado dentro do tempo pré-estabelecido, de maneira clara e didática, com iconografia agradável. Durante a arguição, respondeu adequadamente aos questionamentos dos membros desta comissão julgadora, demonstrando erudição no tema e adotando postura adequada. Assim, esta comissão julgadora considera o candidato aprovado, adicionando um voto de louvor e distinção. São Paulo, 5 de maio de 2021, e eu, como presidente, assino esse documento.
Parabéns.
Parabéns.
Agora é doutor de verdade.
Não, obrigado.
Obrigado pela participação de todos, obrigado aos membros da banca, incluindo o professor Luiz Medina, e parabéns. Mais uma vez.
Obrigado. Bob, obrigado.
Obrigado, professor.
Parabéns. Bom ver vocês.
Incrível.
Onde vai ser o jantar aí?
Pô, acho que ele vai pagar no bandejão aqui mesmo.
Bandejão?
Fecha às 8. Às 8, né? Não vai dar tempo. Não vai ter jantar.
Imagina.
A culpa é do coronavírus.
Pô, eu trouxe o Jackson.